right time. So this is the sort of starting, right? And we'll now come to the main point today, the main idea today, that is basically teriparatide, right? Now, teriparatide is a revolutionary molecule in management of osteoporosis. I think there is, just like I would say in diabetes management, there is an era before insulin and after insulin, right? I think insulin kind of changed the complete, from a non-treatable disease to a treatable disease. I think it's a changing point. Same way, just like perhaps statins or perhaps use of aspirin in myocardial infarction or coronary artery disease, or use of metformin in diabetes. I think it's a kind of a revolutionary system. We've completely changed the way in which you manage osteoporosis with teriparatide. Okay, so let's take a case. Let's take a typical example. A similar patient like this is actually currently admitted in a hospital, right? That's the beauty of it, right? So we see these patients very commonly, but we really see them. We see them, but we don't see them, right? That's the beauty of this. So 72-year-old female, she's known case of osteoporosis. Now she's already diagnosed to have osteoporosis. She's taking oral bisphosphonate, right? She's taking an oral bisphosphonate, something like an alendronate, once a week. She's fairly compliant with that. Since the last 1 year, she's been taking it. Now she complains of back pain. Okay. So her family physician does a X-ray, and on the X-ray of the lumbar and the thoracic spine, there are multiple vertebral fractures. Okay. Now, vertebral fracture in an elderly female is again diagnostic of osteoporosis. Back pain in an elderly female, you must rule out vertebral fractures and you must rule out osteoporosis. So it is so common. Tell me one person who is more than 70 years of age, he or she not complaining of back pain. I will not find anybody, right? So such a common symptom, right? Such a common test, such a cheap test, easily available X-ray, anybody can do an X-ray, AP and lateral view you need to do, right? And you find osteoporosis. And her DEXA scan shows a T-score of -3.5. So she is already on bisphosphonate. She has severe osteoporosis. Typically, less than -2.5 is considered to be diagnostic of osteoporosis, and -3.5 is considered to be severe osteoporosis. So she is already having severe osteoporosis. She is complaining of back pain. She has multiple vertebral fractures. So you already have this system in place, right? So what will you do next for this patient? Would you continue the oral bisphosphonate? Would you switch to IV bisphosphonate? Would you switch to a newer molecule, which is Denosumab? Or would you switch to Teriparatide, right? Now, a brief argument for each of them. Continuing oral bisphosphonate does not make sense because she clearly had new vertebral fractures. Switching to IV bisphosphonate may be a decent idea, but in terms of mechanism, you are doing nothing new. You are, using the same mechanism in which actually failed, right? So it's like saying that, the patient's blood sugar is poorly controlled with one sulfonylurea, so you switch to another sulfonylurea, right? It's not going to make sense, right? Same way, this is what typically happens. Switching to Denosumab is a fair idea, right? You switch from a slightly less, potent agent to slightly more potent agent. However, again, you could completely change the way you treat this patient and switch to Teriparatide, which is a bone anabolic agent. Okay. So what exactly is Teriparatide? But to understand what is Teriparatide, first we need to understand what is parathyroid or what is PTH. Okay. So PTH basically is a hormone in your body, right? And PTH is produced by, so this is your thyroid gland, right? And you have 4 parathyroid glands in the behind the thyroid, right? So this is the parathyroid gland. This produces a hormone which is known as parathyroid hormone, PTH, right? Now the interesting thing about PTH is, which is also seen with another hormone in the body, prolactin. PTH and prolactin, one of the interesting aspects is that generally most hormones in the body are stimulated. For example, if I'm producing free T4 or I'm producing T4 or T3, it is stimulated by TSH. Okay. If I'm producing testosterone, it is stimulated by LH and FSH, right? LH rather. So any hormone in the body is stimulated. But parathyroid hormone is under inhibitory control. It is not under stimulatory control. It is inhibited, right, by calcium sensing receptors. Same way, prolactin is generally produced, but it is inhibited by the dopaminergic pathway. So this is the beauty of this hormone. So it is not stimulated, it is not produced, rather it is inhibited. So what happens is, when you have calcium in the body, it acts on calcium stimulating receptor, which inhibits the production of PTH. But on the other hand, if the calcium levels goes down, right? If the calcium level goes down, there is less stimulation of the calcium sensing receptor and there is increased production of PTH. So basically, as far as the calcium axis is concerned, lower calcium increases the PTH and higher calcium reduces the PTH. That is one thing. What does PTH do? It basically increases activity of 1-alpha hydroxylase, which is an enzyme. Okay, 1-alpha hydroxylase activates 25 hydroxy vitamin D to active form of vitamin D, which is 125 dihydroxy vitamin D. Okay, now this active form of vitamin D helps in reabsorption of calcium from the intestine, also reabsorption of calcium from the renal tubules, right, and also aids in building a calcium bank, right. Second thing which PTH does, it acts on the bones. And what it does on the bones is it increases the bone turnover, right? So it basically increases the bone turnover. And by increasing the bone turnover, it sort of churns out more calcium in the blood, right? So these are the two primary mechanisms as far as the calcium axis is concerned. The other way in which PTH is regulated is by phosphate, right? And this we all know, and nephrologists know this very well, right? So increased level of phosphate basically stimulates production of PTH. And what PTH does is, PTH causes phosphaturia. So it causes washing out of phosphate from the kidneys, right? So again, increase of phosphate increases PTH, and increase of PTH has a negative feedback on phosphate. It tends to reduce the phosphate level. But there is an opposite action in calcium. So reduced calcium increases PTH, and increase of PTH increases the serum calcium level. So there is a differential action of this, right? So this is how the parathyroid molecule works. What we'll be focusing on is the action of parathyroid on the bones. So let's think about it, right? Now, what exactly is teriparatide? So now we understood that how the PTH acts on the bone. Now we'll understand what exactly is teriparatide. Now a normal PTH molecule, the routine PTH molecule has 84 amino acids. Now somebody thought that perhaps, remember what basically PTH does on the bone is it breaks the bone, increases the turnover, right? So technically speaking, teriparatide should have a negative effect on the bone. In fact, patients with primary hyperparathyroidism tend to have osteoporosis, or tend to have weak bones, tend to have more fracture risk. So it is quite counterintuitive that actually teriparatide has a positive effect on the bone, and it is used in treatment of osteoporosis. Technically though, from a mechanistic point of view, it should cause worsening of osteoporosis. So that is one of the reasons why they thought, let's try using a shortened molecule of PTH, which just stimulates the PTH receptor, but it does not have the complete action, right? That was the idea. So they came up with a 34 amino acid molecule, right, which acts on the PTH receptor. So this still acts on the PTH receptor. It stimulates the PTH receptor, but it is not a complete parathyroid molecule. And this 34 amino acid sequence molecule is basically teriparatide. Okay. So what is teriparatide? Basically, teriparatide is a shortened 34 amino acid sequence of PTH, right? However, later on, when they actually made a PTH molecule, complete 84 amino acids, they found that this effect was similar to the effect of teriparatide. So at the end of the day, making a shorter sequence molecule was not, really helpful, but perhaps, it stayed on, and now it's being widely used in clinical practice, and it does the job which it is supposed to do. Okay. So now the question comes. Now, this is the interesting question, right? Think about it. So if you're listening to this, think about it calmly. Teriparatide right, parathyroid hormone breaks the bone. It increases the bone turnover. Yet, it should cause weakening of bones. It should make the bones weak. And that is exactly what happens in patients with primary hyperparathyroidism. However, in patients with osteoporosis, we actually use a PTH like molecule for treatment. There is completely a contradictory system, right? How this happens is this is what we'll discuss. So basically, for that, to understand that, you need to understand the concept of bone turnover. So basically, what happens is the bone, just like I think, life and death are interlinked, right? Remember this. There is no life without death, and there is no death without life, right? Try and think of it. So a lot of people say that, uh, every day we live, live a day of our life. Or you can, glass half full or glass half empty. You can say that every day we live, we inch one day closer to our ultimate death. So in the same way, like life and death are interlinked with each other, the bone formation and the bone breakdown are interlinked, right? So you have the bone formation. It's like chicken and egg, right? So bone formation, which produces bone breakdown, which produces bone formation, right? So this is the bone turnover, or this is the bone formation cycle, or the bone cycle, right? So you have the bone formation, which then activates the bone breakdown, which further activates the bone formation, right? So this is a complete cycle, right? Now, just like any cycle, no cycle is perfect, right? There is no cycle which is absolutely, uh, perfectly in its system. And that's the nature of what is known as entropy, right? So those who, try to sort of follow metaphysics and, metaphysical aspects, they'll understand one of the key aspects of the second law of thermodynamics is that entropy in the universe always increases. The entropy, the chaos always increases. Entropy never reduces, or the world never goes into a state of low entropy, right? So the chaos always happens. And hence, like any other system, the system of the bone turnover is also not a perfect system. So at certain points of time, the formation is more than breakdown. That typically happens in a growing age, right? So when a young children, the bone will grow, the formation will be more than the bone breakdown, right? There will still be a cycle, but the formation precedes the breakdown. Then there is a period of time where the formation is equal to breakdown. And when you have old age, and when you develop osteoporosis, at that point of time, the formation is less than the breakdown. So in initial period, during the growth phase, you have net positive, then you have a neutral phase, and then you have a phase where there is net negative, right? So this is how basically life functions, right? And this is the period of time where you have a osteoporosis which develops. So how do you take advantage of this situation? So we know that parathyroid molecule increases the bone turnover. So what they noticed is, and very interestingly, they noticed is that there is a small window of time, which is known as an anabolic window, where parathyroid stimulates the bone formation. It increases the bone formation, but it does not increase the bone breakdown, right? So it does not have any effect on the breakdown. So there is a small window of opportunity, right, where the formation happens because of the, so there is a dissociation between the cycle. So the formation occurs, but the breakdown does not happen, right? This period of time is known as the anabolic window, right? And interestingly, what they found was, so if you give parathyroid continuously, if you give a continuous infusion of parathyroid, or in your body, if the parathyroid production is continuous, then at that point of time, the formation and breakdown will be linked. And in fact, eventually, the breakdown will be more than the formation. But when you give PTH intermittently, right? So you're giving a bolus, then again giving a bolus, then again giving a bolus. If you're giving it intermittently, the anabolic window, the window opens up, right? It's very fascinating, right? So what I'm trying to tell you is, When it is intermittently given, when PTH is intermittent, there is more bone formation than there is breakdown. But when PTH is given continuously, there is, more breakdown eventually. There is initially both formation and breakdown, but eventually more breakdown. Now, those who are, I think there are gynecologists also listening to this talk, they will associate this with another hormone in the body, the GnRH, right? We know that when GnRH is given continuously, it inhibits FSH and LH production, right? We use this. How do we do this? We use this leuprolide and GnRH analogs, right? Which we give in a high dose continuously, right? So we give a leuprolide depot. So by giving leuprolide depot, what do? We inhibit FSH and LH. But at the same time, if I give GnRH in a pulsatile way, if I give a pulsatile GnRH, it stimulates the FSH and LH production, right? So that's the beauty of hormones in the body. So not only these hormones act in a particular way when given in a particular way, but also it has completely opposite action if it is given in a different way. So in the same way, and this is the analogy which you should all remember. So in the same way, when you have PTH, which is given intermittently, it opens an anabolic window where there is more formation than breakdown. But when PTH is given continuously, it produces a bone breakdown. Same way, when GnRH is given intermittently, it stimulates FS and LH production. Whereas if GnRH is given continuously, it inhibits the FSH and LH production, leading to a situation which is completely opposite, right? So this is what typically happens. Also, what is very interesting about this sort of percolates to the use of teriparatide also. The PTH molecule has different action on different types of bone. So you have two main types of bone in the body. You have the trabecular bone and you have the cortical bone, right? Now, what teriparatide does, or what PTH molecule does, is that it tends to have more effect on the trabecular bone, and it tends to be sort of neutral as far as the cortical bone is concerned, right? So it tends to have more effect on trabecular. Now, why this is important is there are three main sites in the body which we check in a DEXA scan. These are three important sites where fracture happens. One is the vertebra. Second is the radius. And third is the femur, right? Or the neck of femur to be precise, right? Now, all these three areas have difference in terms of cortical versus trabecular bone. So vertebra has both trabecular and cortical bone in equal proportion, right? Rather, it has slightly more trabecular than cortical bone. Radius tends to have more of cortical bone than trabecular bone. Femur tends to have both cortical and trabecular bone in equal proportion, right? So if you take this into account, where do you think teriparatide will be most effective? Vertebra. Why? Because it has more trabecular bone. And we know that PTH works better on trabecular bone. However, it will not have any effect on the radius. In fact, we have seen this also. We take the patient, give them teriparatide, and when you look at it, there is hardly any benefit as far as the radius is concerned, right? So there is no impact on the radius, but the vertebral BMD improves, right? And as far as the femur is concerned, you tend to still have a good effect on the femur because it has a good trabecular bone, right? It tends to have a positive effect on the trabecular bone. So again, for endocrinology residents who are listening to this, this is a very important lesson you have to understand, that teriparatide tends to have a differential effect on different parts of the bone, and hence it will definitely reduce vertebral fracture. It will in fact heal the vertebral fracture, but it generally does not impact the radius, and this patient will still be vulnerable to develop a cholesis fracture or the fracture of the wrist. Okay. So what are the indications for use of teriparatide? So we understood the basics of it. Now let's understand how you use it in clinical practice, right? So the approved indication for use of teriparatide, of course, glucocorticoid-induced osteoporosis. It is, of course, useful in osteoporosis in postmenopausal women, which is common form, and osteoporosis in men, right? So it's a usual indication. There's no extraordinary. But in practical terms, where do we use teriparatide? We typically use teriparatide in osteoporosis in three situations. One is patients already having T-score less than minus 3.5. So like we discussed in the first case, that patient had a T-score already of minus 3.5 or less. In that scenario, you directly use teriparatide. And remember, I'm talking about T-score at the vertebra or at the spine and the femur and not at the radius, because it is not going to benefit at the radius, right? So this is an important aspect. Second, if the patient is already having osteoporosis and has a fragility fracture, okay, so this also becomes a severe osteoporosis. So if the patient has osteoporosis, patient already develops myocardial infarction, then it is a more serious condition than the patient likely to develop myocardial infarction, right? So primary and secondary prevention. So if the patient already has a fragility fracture with osteoporosis, it becomes prudent to consider using teriparatide. And third is, if the patient is already on bisphosphonate or denosumab or any other agent and develops a fracture on these agents, so patient is already taking treatment but yet develops fracture, you need to give a more powerful agent, and that is teriparatide, right? So this is what you have to understand. And what you also need to understand is why teriparatide is different from denosumab and bisphosphonate, because teriparatide is a bone anabolic agent. Okay, the other ones basically are anti-resorptives. So bisphosphonate prevents the resorption of bone, it prevents the breakdown of the bone, but teriparatide actually stimulates the formation of bone, which is completely different, right? So it actually has a positive impact rather than have to stop the negative impact. So that is the beauty of teriparatide. Okay, what are the contraindications for teriparatide? First of all, you will not use it in children. So anybody with a open epiphysis, right? So if you have a child with an open epiphysis or in a growing phase, you don't use it, right? Don't use it in children. Second, don't use it in patients having bone metastasis, right? So already has history of bone mets or any kind of bone malignancy or multiple myeloma or anything like that. Don't use it. Don't use it in patients already having hypercalcemia, right? So you need to check the calcium before you start the treatment, right? So if the patient has hypercalcemia, you don't use it, right? You don't use the molecule, okay? You don't use the patient having very high alkaline phosphatase. So one very useful, cheap, easily available test before you start treatment is to check for alkaline phosphatase. And if the patient has high alkaline phosphatase, which you don't know the reason for it, first diagnose it and then use teriparatide, right? So you need to know a reason why the ALP is high, and those patients having high alkaline phosphatase, you generally avoid using teriparatide, right? You don't use it in, of course, rare conditions like Paget's disease. We don't see that very commonly in India, right? So these are all other conditions where they are contraindicated. And of course, you know, you will not use it in patients with primary hyperparathyroidism. If the patient already has PHPT, you don't use it. So these are some broad contraindications for use of teriparatide. Okay, practically, where do you use teriparatide? We use teriparatide typically in patients where do I use? I typically use it in 2 or 3 scenarios very commonly. I often use it in a patient already having a fragility fracture, right? So if a patient has, you know, comes already with a fracture, is admitted, she's admitted in the hospital, I consider using teriparatide. There is some data that teriparatide also helps in fracture healing. So of course that data is contested, but there is some data to suggest that it also aids in fracture healing. So you can use it in a patient. I typically use it in patient already having a fragility fracture. I also use it in patients who come with, who are, you know, already having osteoporosis, and for some reasons they have to be given steroids for a long period of time, right? So if the patient has, for let's say, some autoimmune disease where you have to give glucocorticoids, so patient has you know, perhaps you know, immunosuppression is being given, right, for whatever reasons, that patient already has a baseline osteoporosis. In such a scenario, again, teriparatide is very useful. So these are 2 common scenarios where I often use teriparatide. And third very common place is patient coming with vertebral fractures. So if the patient, you know, comes with back pain and so on and so forth, and already has multiple vertebral fractures, you know, it is because of osteoporosis and not because of malignancy. In such a scenario, you would consider using teriparatide. So these are 3 very common scenarios where I practically use in my own practice teriparatide. How effective is teriparatide in osteoporosis. So this is a small video to show the kind of the effect of this. So you can see, and this is actually a bone biopsy taken from a female who was given teriparatide for 21 months. So you can see on the left side, you can see here the bone over here. You can clearly see the pores over here, right? Can you see this, right? So you see the pores. And the same lady, when you did this, look at how the bone completely looks different, right? It's in fact magic. You would naturally, even if I tell to my 7-year-old child, she will tell me that this bone, the one over here, this is definitely more stronger than the bone on the left side, right? So that's the beauty of it. Okay. Okay. Yeah. So the other important aspect of teriparatide, and why that is one of these, again, the reason why it is very useful, is that it actually improves the bone microarchitecture. It changes the bone's structure, and you can, that was clearly shown in the earlier slide. The microarchitecture clearly changes. This, unfortunately, no other osteoporotic agent at this point of time improves bone microarchitecture. And again, endocrinologists listening to this will try and understand this, that see, DEXA scan only gives you one aspect. It gives you only one aspect of osteoporosis is not always dependent on DEXA. Sometimes a patient can have almost osteopenia or almost normal bone mineral density and yet can develop fractures, right? Other patients might have a very poor bone mineral density and yet may not have fracture. Like I said, fracture is a multi-dependent process. It's not dependent on just BMD. It is dependent on many other factors. And one of the factors where it is dependent upon is the bone microarchitecture. And the only agent where the bone microarchitecture actually improves is actually teriparatide. Okay, you can see this a comparison between teriparatide and alendronate. So they what you see here, this one is alendronate and this one is teriparatide, right? I think it's an unfair comparison. You're comparing, perhaps middle order batsman like something like Akshar Patel with Shikhar Dhawan, right? I think that there's a huge difference, right? Both are good batsmen, but there is a clear difference, right? No doubt about it. So you can see here the bone mineral density clearly at lumbar spine improves significantly compared to alendronate. And if you see at the femoral neck, again you can see teriparatide with oral alendronate. This comparison is important because in clinical practice we often prefer using alendronate instead of teriparatide, and I think this is clearly a difference here. Again, you can see from this study clearly you can see teriparatide has at multiple places as a clear benefit, except for radius, right? What you see here is distal radius. So in radius, teriparatide does not help, but other places it definitely helps. But at radius also you can see even alendronate, there is not much improvement in terms of bone mineral density. Okay. If you talk about in terms of absolute data, absolute risk reduction of fracture or a new vertebral fracture is by almost 9%, relative reduction of 65%. And if you talk about non-vertebral new fractures, there is reduction about 3% with a relative risk reduction of 53%, right? So there is an absolute reduction, and the vertebral fracture is quite remarkable, right? So 10% is quite significant in terms of clinical practice. Okay. Now let's talk about some practical aspects of administration of teriparatide. And again, those who are listening to this talk, and if you have again orthopedic surgeons, spine surgeons, the other things, we can sort of discuss the practical aspect. I think there's a question in the chat also. I'll try to answer that here itself. Somebody asked me, after an acute fracture, how soon can you start teriparatide? I'll say next day. You can actually start teriparatide unless, of course, you have ruled out contraindications. You have ruled out, you have done the baseline investigations. If you've done that, you can start teriparatide the next day. There should be, there's no reason to wait for it. That is one of the beauty of teriparatide, that you can immediately start the drug almost the next day. What test you have to do before starting teriparatide? You have to do, of course, the calcium, right? Like I said, patient having hypercalcemia, teriparatide is a contraindication. You need to do alkaline phosphatase, right? Again, cheap test, easily available, but you have to do it because, like I said, undiagnosed alkaline, high ALP is a contraindication, right? So you need to first find out the etiology and then you have to treat it, right? Third, of course, you have to do a DEXA scan if it's not already done, right? I'm assuming that since you're treating osteoporosis already on a DEXA, but if you're not done it, you should do it. One test we should consider using, we don't use, is P1NP, right? P1NP is a bone turnover marker. It's a bone formation marker. I'll show you the use case for this, but of course, bone turnover markers are not available everywhere. We had a separate lecture on that. It's there on the YouTube channel, Endocrinology India YouTube channel, so you can have a look at that. But P1NP is another useful test. So if you're, an endocrinologist treating these patients, it would be a good idea. P1NP actually helps to see the effectiveness of Terperatide and also the compliance of the patient, right? So it's a useful test if you have to do it before starting the treatment. So these are some of the tests you have to do it. Now, how to administer Teriparatide? Teriparatide is a subcutaneous injection. Okay, it's given just like you give insulin, right? So it's very similar to giving insulin. In fact, it is so similar that, and this I think, please, again, if you're practically using it, please try to listen to this. Currently in India, the Teriparatide which is available in cartridges with a pen which is separate. Now this pen is typically similar. It's a generic type of pen which is typically made mainly for insulin use. So you'll find markings on the pen which are mainly made for insulin use. They are not used for practically for Teriparatide use, right? So what you have to understand is, if you are using an insulin, so if you're, for example, we have a sponsors today, Osteofract, right? So if you are using an Osteofract device, it comes with an insulin type pen. So the dose we have to give for Teriparatide is 20 microgram. Okay, so the dose is 20 microgram given subcutaneously daily. We typically give it at bedtime, right? Of course, there is no specific time for it, but we typically give it at bedtime, right? So 20 microgram daily subcutaneously at bedtime, that is the dose. But what you have to understand is, since we use an insulin pen and you find units in the insulin pen, you have to give 8 units. Okay, so you have to use 8 units. So in an insulin pen, if you're using it, you're putting the cartridge in an insulin pen, right? Typically, a lot of these companies use the Lilly's pen, which is a very nice pen. So you use Lilly's pen or any other insulin pen, you have to give 8 units. Now, again, there is a confusion, because if you're using some other pen, for example, if you're using Zydus's Bone Max PTH, the markings are different. So in a Bone Max PTH, you have to use 0.8. There is a marking called 0.8. Today, I just taught one of the patients of using this. There's often patients don't understand this. So you have to teach the patient the right way of using it. So if you're using a typical pen, and most of the, I think 9 out of 10 companies use a typical insulin pen. If you're using a typical insulin pen, you have to use 8 units. Please remember this. So if you're writing the dose also, it would be a good idea to write the dose as 8 units, bracket 20 microgram daily subcutaneously at bedtime, right? So that is how typically I write the dose. So if I'm prescribing Osteofract, this is how I typically prescribe it, right? So that there is no confusion. So that, because what happens is, sometimes you've seen patients you're written 20, so they take 20 units. If they take 20 units, you can clearly see it's almost 3 times the dose. So they are actually taking almost close to 50 to 60 microgram per day instead of 20 microgram per day. They're taking 3 times the dose. So not only it becomes more, dangerous, but it also becomes perhaps, more expensive also, because, typically the dosage is given, the cartridge lasts for about 28 days. In this case, it often lasts a little longer. So the method of administration is similar to how you administer insulin, right? You have to, of course, change the side, your arms and your abdomens and your thighs, rotate the side, change your needle, all these things, a typical insulin dosage. Anybody who uses insulin knows this, and you have to use the same methodology, right? So this is the practical aspect. Like I said, the dose is 20 microgram and you have to use 8 units in an insulin pen, right? The duration of therapy typically, okay, this again, I think orthopedic surgeons also need to understand this. The total duration of treatment for Teriparatide is 2 years or 24 months. Okay. So when you prescribe Teriparatide, don't prescribe Teriparatide for 3 months. We often see off-label use of Teriparatide for 3 months, 4 months, 6 months, right, till the fracture healing occurs. This is completely off-label use. If you're treating this patient for osteoporosis, the duration of treatment of Teriparatide for osteoporosis is 24 months. You have to use it for 2 years. Okay. So when you're prescribing it at that point of time, it should be made clear to the patient that this duration of treatment is 2 years. The duration of treatment is not 3 months, right? So this is an important point you have to understand. Okay. So the duration of treatment, total duration of treatment is, 24 months. You can, of course, and now we have bone turnover markers. So again, endocrinologists listening to this will find this useful. And this is the, a similar uh, protocol as what we use in clinical practice. What we do is we first measure the P1NP before starting the treatment. Then we start the teriparatide and repeat the P1NP at 1 month and 3 months. Okay. This tells us two things. It tells us the effectiveness of the molecule. It also tells us the compliance of the patient. So optimal response is about 10 microgram per liter increase of P1NP above baseline, or an absolute value. Sometimes if the first sample has not been taken or whatever reason, absolute value more than 69 nanogram per liter after a period of 3 months is sign of a good response to teriparatide, right? So this you have to understand, but also you have to remember, if you're shifting the patient from an anti-resorptive drug to a bone anabolic drug, the P1NP rise can take something like a 6 months. So it's better to measure it after 6 months. So suppose you have given bisphosphonate, or the patient was on bisphosphonate, and after that you have given teriparatide, you repeat the P1NP after 6 months instead of at 1 month or 3 months, right? So this is a practical use. This, like I said, it helps you to see the effectiveness of treatment. It also tells you the compliance of the patient, and that is something you have to be useful. We also use practically teriparatide in a very different way. I'll show you how we use it, right? I'll come to that in a few minutes. What you have to monitor? You have to monitor the calcium level, right? You have to monitor the vitamin D level, right? You have to monitor. So these are two important things you have to monitor. Of course, you have, P1NP we already saw, right? If you have that facility available, and you should repeat the DEXA scan annually, right? So these are some of the things you have to consider doing it as a monitoring parameter. Okay. You have to, of course, if the patient is not on calcium, you have to prescribe calcium, typically 1000 to 1200 milligram per day, and vitamin D typically 800. Maintenance dose is 800 international unit per day. Don't give more than 1500 milligram of calcium, because these patients can develop hypercalcemia on teriparatide. So typically the dose should not exceed 1500 milligram per day. So typically 1000 to 1200 milligram per day is a median dose. What is an expected side effect? One very common side effect, and that is the reason why we prescribe this at bedtime, is sometimes it can cause orthostatic hypotension, right? So it can cause orthostatic hypotension. It can cause initially a little bit, and you have to be careful. Remember, these are elderly patients, and if they fall from a standing height and they've just started teriparatide, they'll fracture again, right? So you have to be careful. Okay, so orthostatic hypotension is an expected side effect. Of course, if the patient is taking the wrong dose, we have also seen hypercalcemia develop it's very rare, but we have seen it develop. We had seen one patient who was taking 20 units instead of 20 microgram. And hence, after about 6 months, the patient came with severe hypercalcemia, renal dysfunction, and so on and so forth, right? So you have to be, of course, such problems can happen. So you have to be careful. No other major side effect. Sometimes it can cause some skin reactions and so on and so forth, but otherwise, they are very, very rare. Patients often, and this is what doctors often tell me. Okay. So I'm sure, when I said you have to give the treatment at 24 months, often you have, you have a lot of orthopedic surgeons in our own hospital would say that those help to con treatment. You have to take injection daily like an insulin for 2 years. It is not cheap, right? Is there a solution for this? Fortunately, right? And this is, I think, the meat of the talk today, right? This is the best part of the talk today. Answer is actually yes. There is some very interesting data. I think, all of you are listening to this. I think you would, and this is how we have started. Since we read this data, since we, analyzed this, we actually found that this is a good way of using it. And I think it not only reduces the cost of the drug, but it also improves probably the efficacy and the patient's compliance, right? So what's the magic, right? Now, there is an interesting study done by a particular group in Japan where they analyzed weekly teriparatide. So instead of giving teriparatide 20 microgram daily, they gave this patient 60 microgram once a week. Okay, so they gave this dose 60 microgram weekly. they compared, they did a randomized control trial. I think the name of the study is Tower study. You can have a look at this. This is available, free full text is available. If anybody is interested, they can send me a text and I can send the full text of this article. So this was a randomized control trial where they compared 60 microgram weekly dose of teriparatide with 20 microgram, the standard dose, daily. What they found was it was equally effective. In fact, the reduction of new vertebral fractures was less with the new onset of vertebral fractures. New onset of vertebral fracture was actually so less with 60 microgram weekly dose. So the weekly dose was actually more effective than the daily dose, which is very interesting. Interestingly, the only problem was that the weekly administration of teriparatide, the problem was that it led to more side effects. So more orthostatic hypotension, more nausea, more GI side effects, which were observed. Also, they had to monitor the calcium of this patient at a regular basis. So what they did was they did another trial where they used same Japanese group. They used 30 microgram twice a week. Okay. So they used 30 microgram twice a week. So instead of using 60 microgram weekly, they used 30 microgram twice a week. Very interesting, right? So they used a different dose, smaller doses in 2 batches, right? Again, if I tell anybody to take an injection twice a week, I don't think they'll mind, right? Most patients do not mind using twice a week. So what we typically do in our practice, we start the patient on 60 microgram weekly. We have started doing this, right? And, once the patient, if the patient does complain of side effects, we switch to 30 microgram twice a week, right? Instead of 60 microgram as a single dose. In certain patients, they still don't, are not happy. So we switch to 20 microgram 3 times a week instead of 60 microgram daily. Of course, we don't have data to back the 20 microgram 3 times a week dose. But of course, we monitor P1 and P, and we do see a good response even with that dose. That's the interesting part, right? So I think this is the interesting aspect of the entire study. So you can use weekly dosing, right? And typically, if you're using the same pen, right? Remember, it's an insulin type pen. You have, instead of 8 units, you use 24 units. Simple, right? तुमको एक ही बार prick करना है, but तुम्हें 3 times ज़्यादा dose देना है, right? So you use 24 units instead of 8 units. Secondly, if you're using this, use 12 units, right? Instead of 8 units, you use 12 units twice a week. So both are equally effective, right? Both are, interesting concept, right? So this concept basically comes from the fact, and the argument is that since you are using an intermittent dose, so the benefit of PTH is actually intermittent dosing. So since you are anyways using the concept of intermittent dosing, why not, instead of daily or 24-hour cycle, why not use weekly cycle? And this is what is known as an extended anabolic window. Okay. So this is known as an extended anabolic window. This concept is now being extremely used. I think this will catch up very fast. The weekly dosing of teriparatide, it's extremely intuitive, and it will make the use of the molecule much better, right? You will actually use the molecule more. You're using the same dose, but instead of giving it daily, you are giving it slightly smaller dose also. So you are actually, saving money also, right? So like I said, the dose is 60 microgram once a week or 30 microgram twice a week. Both the things have been proven with clinical trials. There is data to prove it. There is a randomized control trial. There is a trial, I think the Tower trial, or maybe one of the trial, was published in JCM. So it's published in the leading endocrinology journal. It is not a simple small study. It's a properly well done study done in a very good journal. Okay. Twice weekly, like I said, right? And I think the cherry on top of this, right? We have PGI Chandigarh, right? You have the endocrinology department in PGI Chandigarh. Dr. Sanjay Badada, I think he's the bone man of India, I would say. A lot of people, again, endocrinologists who are listening to this would know him. Their group have actually done a small study where they use in Indian patients where they use 60 microgram and they found non-inferiority. So I think again you can probably look up this. I think probably Dhiren, you can share this study. I think there's a study there. This I think there is. It's now you have a study in Indian population also, and it works equally well in Indian population. So you are saving a lot of money. You are saving the patient's frequent pricks, and you are improving the compliance of the patient by giving weekly dosing, right? I think this concept has to be, and those who are listening to this perhaps can probably take this up. And I think this solves the problem of the 24-month use. Patients will not, if you tell a patient, I am going to give you the most powerful available agent for osteoporosis, and I'm going to give you weekly, nobody will say no to it, right? I trust me, right? And we have patients and who use it, right? Okay. What are the other uses of teriparatide? Back pain, and I think this is what we learn from spine surgeons. Spine surgeons always use teriparatide when the patient complained of back pain. So I said, yeah, I mean conceptually, to theek hai. Vertebral fractures are being healed. There is reduced vertebral fractures. It should cost, but there is actually a clinical trial where they found that on a visual analog scale, teriparatide, when compared to other agents, including calcitonin, reduces the back pain. And this we have seen in clinical practice also. So if you're prescribing teriparatide for a patient with vertebral fractures, not only does it improves the bone architecture and reduces the risk of future fractures, but it also reduces the pain, right? So this is again one of the major benefit of teriparatide. So this is the study, right? EFOS study. I'm not going to details of this, right? But you can see on there was 55% reduction of pain in the visual analog scale, right? I think somebody asked, okay. We'll come to the questions later. Secondly, fracture healing. Okay, orthopedic surgeons for time. I mean, everybody in this group knows that orthopedic surgeons, including the sponsors of this event, know that orthopedic surgeons use teriparatide for fracture healing. The problem is it's conceptually very true. Conceptually, it does work. The only catch is we don't have very good data for it, right? But it does work. So again, if you are having a osteoporotic fracture, you can start the patient on teriparatide. It will actually improve the bone healing also. It will improve the bone turnover. It will improve the bone microarchitecture. Also, it will also help the fracture to heal. But remember to continue the use for 24 months, right? Use the complete duration of treatment. Don't stop it at 3 months, right? Hypoparathyroidism. In fact, I think Dhiren knows this, and we talked this to a lot of companies who manufacture this drug. Endocrinologists used this off-label for hypoparathyroidism. My friend, Dr. Shrikant Somani, who is an endocrinologist from Ahmedabad, has a paper on this. You can look it up. The use of teriparatide in hypoparathyroidism. The benefits of this is, remember, hypoparathyroidism, basically, they don't have PTH. So what we are doing is, just like, you have insulin deficiency, in type 1 diabetes, you use insulin. In patients with hypothyroidism, we use Theranom, right? Or Eltroxin, right? Whatever. Same way, in a patient with hypoparathyroidism, we use PTH. So the best treatment could be nothing better than teriparatide, right? In this case, we basically use, the problem is we have to use a slightly higher dose. So we use 60 microgram BD. The reason is that the calcium increase happens only for 4 to 5 hours. So if you give it once a day, in the evening, the patient starts developing symptoms again. So you can perhaps use it twice a day. Okay, so that is one of the sort of benefit, or you can say one of the difference. So the cost becomes higher. That's one of the challenge, but the quality of life improves. And also there is no study done on this. Nobody will do this study. It's an orphan molecule. But I think maybe some of us can take up this. But the thing is, remember, in patients with hypoparathyroidism, they have low calcium and high phosphorus, right? So the calcium is low and phosphorus is high. How do we treat hypoparathyroidism? We give these patients calcitriol, which is an active form of vitamin D. So calcitriol increases the calcium, but it also increases the phosphorus. And when there is increased calcium and phosphorus, so there is calcium into phosphorus, it starts getting deposited. And these patients start developing in future nephrocalcinosis, renal failure, and they can also develop cataracts. By giving teriparatide, you reduce the requirement of calcitriol, reduce the dose of calcitriol, you reduce the phosphorus also. So what you do is you reduce the phosphorus, you reduce the deposition of calcium and phosphorus, and because of this, the patient actually benefits better, right? So any patient with hypoparathyroidism, in addition to calcium, calcitriol, vitamin D, you should also give this patient, consider giving this patient teriparatide. We have seen very, very good benefit in these patients with the use of this molecule, right? It's used in dentistry also. Chronic, bone resorption which happens in teeth also can be treated with teriparatide. Right? Of course, I don't have any experience with this. I think maybe dentists would be able to tell us better. What is the relation with other agents? Bisphosphonate, remember, what you have to remember is teriparatide with bisphosphonate blunts the effect of teriparatide, right? So I'll show you this. I don't have this picture, but basically teriparatide when given with bisphosphonate, because remember, teriparatide increases the bone turnover, bisphosphonate reduces the bone turnover. So they have an opposite effect. So they blunt each other's action. So again, combination therapy is not a great idea. Teriparatide after bisphosphonate has to be given sometimes, because if the patient develops fracture, like the first case we talked about, if the patient develops fracture on bisphosphonate, you have to give teriparatide. So in this case, the benefit of teriparatide is a little slower. So it takes a little time for teriparatide action to really kick in. Denosumab with teriparatide has been tried in some studies and found to be very effective, right? So it can be used in combination, but generally speaking, it becomes very expensive in India to use this combination. So it's better to use teriparatide rather than to use. And once the teriparatide 2-year therapy is over, then after that you can switch over to denosumab, right? And of course, denosumab or bisphosphonate after teriparatide is a standard of therapy. So remember, teriparatide you use it for 2 years, and then after that you switch over to bisphosphonate or denosumab. Right? So I'll just summarize a few important points. First point, if the patient has fragility fracture, right? The patient has osteoporosis. So if you have fragility fracture, you have osteoporosis unless proven otherwise. So you don't need DEXA, you don't need any other test to prove it. Fragility fracture is diagnostic of osteoporosis. First thing. Second important take-home message, teriparatide is a PTH analog with 34 amino acid instead of full 84 amino acid. It uses the concept of an anabolic window to increase bone formation and hence has a bone anabolic effect, and hence it's useful in treatment of osteoporosis. Third, teriparatide is given typically in the dose of 20 microgram once a day subcutaneously at bedtime. You can use a different dose, that is 60 microgram once a week, right? A different dose you can use. You can use 30 microgram twice a week. Both have data available, right? But remember, if you're using with insulin pen, right, 20 microgram is equal to 8 units, 30 is equal to 12, and 60 is equal to 24 units, right? So keep this in mind when you're using this molecule, right? Okay. And the fourth important point, I'll just end this. You can use bone turnover markers like P1NP to, monitor the therapy. And typically we repeat this after generally 3 months, and P1NP value increased by 10 or absolute value more than 69 is suggestive of good response to teriparatide. And in that case, so this is what we typically do. We start the patient on once weekly teriparatide. We see the response. We can check the calcium, monitor other things. We check the P1NP at end of 3 months. And if the value is good, we continue weekly. Otherwise, we consider switching over to more frequent dosing and perhaps increasing the dose. Right? So thank you for a patient listening. I think this was a new idea which we tried to bring. We'll be happy to share the thing, but I just need a small request from you. This is a small feedback form we have. It's a quick, it'll take just 5 minutes. So I want your valuable feedback on how the talk was. Perhaps, in the future, if you can use the same way of presenting it, please leave your feedback. Also leave your email address, WhatsApp number, whatever. If you're interested, we will, keep you in touch. We'll keep you in loop for any future events, future talks where you can just participate in that. We'll also, of course, once you have the YouTube video for this available, we'll load it up on the internet, and in the same channel, we'll send you the link for the same, right? So these are, so again, requesting you to put a feedback. This is the link for the feedback. Dhiren, can we take the questions now?